Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clanet, serving as allocated session assistant to ensure a seamless experience. Clanet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as a Jyotra partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session is perioperative management of modern non-anesthetic drug. Now, I would like to invite Dr. Pradeep Jain, sir, to proceed. Over to you, sir. Thank you.
Yeah, good evening, everybody. Welcome to the Indian College of Anesthetics webinar series 284. On the topic is the perioperative management of modern non-anesthetic drugs. The moderator are Dr. Manjula Sarkar. She is the professor, Department of Anesthesia, D.Y. Patil Medical College, Navi Mumbai. And she doesn't need any introduction. She's a very familiar figure, personality. She is a great teacher, anesthetist par excellence, and great human being. She has many publications, national, international, and she is mentor and guide for the undergraduate, postgraduate, and master students. Then the second moderator is Dr. Yogita Patil. She is an additional professor in the Department of Anesthesia, St. GS Medical College and KUM Hospital. Regarding her, she is the faculty in pain medicine, and she has got 20 publication and 2 book chapters. She is the faculty for the simulation also, secretary of the ICA Mumbai Metro branch, and she has written a very good book on ultimate wellness code. And she's founder member of the Anesthesia Academic, and she has received awards also, individual award for COLS promotion at ICACON 2024, and received the President Appreciated Award for ICACON in Maharashtra 2025. May I request the moderator to please introduce the speaker and the topic, please.
I thank Dr. Pradeep Jain sir for introducing us to the audience. And the topic, sir has already told you that we are going to talk about the drugs in relation to anesthesia practice is concerned. Dr. Yogita doesn't need any introduction. If you look it into the Maharashtra state is concerned, or even the national figure, you can say. And Dr. Yogita is going to introduce Dr. Aparna Nerurkar. She's going to be our first speaker of this webinar day. So over to you, Yogita.
Thank you, Dr. Pradeep Jain sir and Manjula ma'am for the warm welcome and my nice introduction. So we take the proceeding ahead. I take privilege of introducing Dr. Aparna Nerurkar. She is additional professor at SAIT at LTMMC Medical College and Sion Hospital in Mumbai. Her areas of interest are anesthesia, and not only anesthesia, she has a degree in medical legal cases as well. So really interesting venture, Aparna. She has won many awards for presenting papers. Her students has got many awards in different conferences. She's part of the team when the biggest kidney tumor was removed in Sion Hospital, and she was part of that Guinness Book World Record holder, one of the world record holder in Sion Hospital. She has a postgraduate diploma, as I told, in medical legal systems and hospital and health administration as well. And she is course director for BSc and OT technician degree in Sion Hospital. So over to you, Dr. Aparna, for your topic on SGLT2 inhibitors and anesthesia considerations.
Thank you for that very warm introduction. And I would like to thank the Indian College of Anesthesiologists for giving me this opportunity to speak on this topic. I'll just share my screen. So I'm going to speak on this very interesting group of drugs, the sodium glucose cotransporter 2 inhibitors, the SGLT2 inhibitors. I expect to cover what are they, how do they work, where will we see them, why should we worry, and how to tackle their use. So before we go there, let me just tell a brief note on what are the SGLT receptors actually. So this sodium glucose co-transporter receptor, they are of two types, SGLT1 and SGLT2. SGLT1 is present in the intestine, the kidney, the brain. And what it does is it facilitates glucose absorption. While the SGLT2 are present in the segment 1 and 2 of the kidney. And what they do with SGLT1 is that they reabsorb all of the glucose that has been filtered out by the kidney. And we all know that the normal threshold is 180 to 200 milligram per kg. So when this threshold is reached and all the glucose is excreted into the urine, it is the SGLT2 and 1 which reabsorb this glucose and prevent the caloric deficit. So of this, SGLT2 take up 90 to 97% of the glucose that has been excreted, while the SGLT1, they take up 3 to 10% of the glucose that has been excreted. But what happens in diabetes? The threshold goes up, but still a lot of glucose is being secreted into the proximal convoluted tube. So now to take this glucose back, more and more SGLT2 inhibitors have to, SGLT2 transporter proteins have to be expressed on the proximal convoluted tubules. As a result, what happens is, along with glucose, sodium also gets reabsorbed. But now, the sodium which gets reabsorbed, it has to be pumped back against a concentration gradient. So, more and more sodium potassium pumps are also activated, which increases the oxygen consumption. And as a net result, there will be diabetic nephropathy. Along with that, what happens is, since now less and less sodium is coming into the tubules, the macula densa, it perceives that there is a decreased glomerular filtration. So what it does, it tries to increase the glomerular filtration by vasodilating the afferent arteriole and vasoconstricting the efferent arteriole. So because of this tubuloglomerular feedback, there is glomerular hyperfiltration. Again, the oxidative stress has increased and the renin-angiotensin mechanism gets activated and there is hypertension. So now, how do this SGLT2 inhibitors work? So when these receptors are there, they are absorbing all of the glucose that has been excreted in the urine. But if we put inhibitors over here, the glucose is not allowed to get absorbed. It bounces back and is lost in the urine along with sodium. So by closing a glycosuria, it reduces the glucose levels in the blood. Along with sodium loss, it creates a diuretic effect. Along with that, it causes the reduction of the tubuloglomerular feedback. So there is nephroprotection. The hyperfiltration is stopped. The erythropoietin release is increased because overall improvement in the kidney structure and function. Another side effect which they have now exploited for its good effect is the effect on the heart. So with this diuretic effect, there is a slight reduction in the systolic and diastolic blood pressure. It improves the heart modeling. It improves the diastolic function. On the blood vessels, it reduces the vascular stiffness and improves the endothelial function. Because of these two results, the heart functioning is improved and therefore it is of use in patients who have heart failure. It also increases the ketogenesis and decreases the inflammatory markers. It improves the fatty liver and it also improves the uric acid excretion. So now we have to know that any drug which gliflozin in its pack is the SGLT2 inhibitor. Dapagliflozin is the most commonly available and used. Empagliflozin is going to be shortly available. There is one drug which is sotagliflozin, which is available, which inhibits both SGLT1 and SGLT2. So where do we need these drugs? Of course, commonly in type 2 diabetes mellitus, though now they have started exploring its use in type 1 diabetes mellitus as well. And these are the ones which we have to be careful about. Heart failure with preserved ejection fraction or reduced ejection fraction, patients with chronic kidney disease, and in bariatric patients because it causes a weight loss. It has also been explored for its use in obesity. Why should we worry? Well, we should worry because there are some significant side effects. Though by itself it doesn't cause hypoglycemia, it can cause hypoglycemia when it is combined with insulin or sulfonylurea. Why doesn't it cause hypoglycemia on its own? Because it is just dealing with the excess sugar that has come into the glomerular filtrate and not the blood levels per se. However, it can cause increased urinary infections because glucose is a good culture medium in the urine. It can cause dizziness because of its diuretic effect. It can cause hypotension for the similar reason and hypovolemia. And the most dreaded complication is diabetic ketoacidosis, which is difficult to detect because it is euglycemic. So when a patient comes for surgery, he is already having a stress. So there can be stress hyperglycemia, but he is fasting. So there will be decreased serum glucose level. In addition, this SGLT2 inhibitors, they cause increased glucoseuria. So again, the glucose levels will come down. So there will be euglycemia or a false euglycemia. Now, the decreased serum glucose levels lead to decreased insulin level, but the stress response leads to an increase in the counter-regulatory hormones. Also, the SGLT2 inhibitors, they stimulate glucagon. All this leads to increased lipolysis, increased ketoacid production, and an anion gap metabolic acidosis, which presents as euglycemic decay. So why should we be worried? So in 2000, as far back as in 2019, a study was done in which they studied whatever is the systematic review of all the publications till then. That 33 publications were eligible, of which 42 reports of euglycemic diabetic ketoacidosis and 5 reports of hyperglycemic decay were noted. They saw that canagliflozin was implicated in 26 cases, and these decays took place few hours up to 6 weeks post-op. The precipitating factors were there were either changes in the diabetes medication, diet modifications, or intercurrent illnesses. 7 of them required mechanical ventilation, 5 went into acute kidney injury, but fortunately they recovered completely. The authors could not find the precise association between the interruption of SGLT2 inhibitors and occurrence of decay, but they did recognize that it was an atypical presentation because it was not associated with hyperglycemia. And they recommended that there should be vigilance towards monitoring plasma and capillary ketones, and large prospective studies need to be conducted to identify the risk factors, which was done in the next study. They studied all the electronic databases till 2022, found 76 publications with reported 99 cases of SGLT associated postoperative ketoacidosis. This was defined as a blood pH less than 7.3 and blood or urine ketone presence within 30 days postoperative. Now, out of these 99 cases, they found that 59 cases had withheld the SGLT2 inhibitors. But if they had withheld for more than 2 days, they found no symptoms. So what they have recommended is that you need to withhold the SGLT2 inhibitors for at least 3 days. However, they again said that large prospective epidemiologic studies needed to be conducted. A single center retrospective analysis of 463 patients on SGLT2 inhibitors was studied to correlate with the degree of anion gap acidity, because what they found was that it may not be a overt decay, but anion gap definitely increased. So they wanted to have a multivariable regression model to find out which of these factors, that is the preoperative anion gap, hold time for medication, 3 known risk factors, emergency surgery, cardiac surgery, and insulin use, plus the presence of non-ketone ions most accurately predicted the occurrence of an anion gap acidosis. So what they found was that there is some degree of anion gap acidosis in all patients in whom SGLT2 inhibitors were not withheld prior to surgery. It was not idiosyncratic as was reported earlier. And out of all these multivariables that they studied, only the holding time prior to surgery and emergency surgery had a significant correlation with the occurrence of anion gap acidosis. So the FDA had already issued a warning in 2022 that canagliflozin, dapagliflozin, and empagliflozin should be stopped at least 3 days prior to the surgery, and ertugliflozin needs to be stopped at least 4 days prior to surgery. Similarly, the Australian Diabetes Society and the New Zealand Society for Diabetes, they also have recommended that one needs to omit the SGLT2 inhibitors for at least 3 days, that is 2 days prior to the surgery and day of procedure for people with diabetes who are on SGLT2 inhibitors. Similarly, the American College of Cardiology has also asked to discontinue this 3 to 4 days before surgery. So why this difference, 2, 3, 4 days? Well, pharmacologically, we all believe that you require at least 5 half-lives for the complete drug to be eliminated out of the system. However, it is noted that the pharmacodynamic effect lasts significantly beyond the effective plasma concentration. So, after 24 hours of cessation, though only 25% of the plasma drug remains in the plasma, the urinary glucose excretion was still elevated up to 40 hours. At 72 hours, once less than 1% drug remains in the circulation, the urinary glucose excretion normalized to the baseline. But stopping this drug needs to be weighed against the risk that you will be precipitating cardiac failure in those patients in whom this drug has been used only for reduced ejection fraction or a preserved ejection fraction heart failure. Also, if you stop this drug for 3 days and don't have any other drug as a protection, you may have hyperglycemia and there may be cancellation due to hyperglycemia on the day of surgery. So then what we do need to do? We ensure that the patients do not have long starvation periods. They remain well hydrated. Adequate glucose and ketone monitoring is done during this long starvation period if they are unplanned or there is unavoidable long fasting. And we do need to give glucose containing IV fluids to mitigate the ketone generation. But is discontinuation really necessary? So in Japan, they had a study it was a prospective cohort study, multi-center, from Jan 21 to August 22. And they screened for SGL2 associated postoperative ketoacidosis till the third postoperative day. However, it was found that in all the 759 patients in whom this was withheld, and they withheld it across a wide range of surgeries, general surgery, ENT, bariatrics, etc. 35% withheld for more than 3 days, while a majority at least had up to 3 days. They received GA with or without regional anesthesia. However, as per their protocol, 92.5% of them has received intraop glucose because in Japan they are using 1% glucose with RL routinely and insulin was used as required. So when this protocol was followed, they found that SAPCA was 0%. What about emergency cases in whom you just cannot stop because the patient has already taken SGLT2 inhibitor? So when such a study was done of 34,671 patients, of which 2,607 patients were on SGLT2 arm, they found that the incidence of DKA was not very different. 3.8% in those whom they were taking the SGLT2 inhibitors, while those who were never taking, still they had 3.5% due to the nature of emergency surgery. So they concluded that preoperative SGLT2 use was not associated with increased post-op decay in emergency surgery. However, here most of the emergency surgeries that were done were cholecystectomy, lap cholecystectomy and transurethral surgery. So should we extrapolate these data? In an academic center, that is in Massachusetts, they saw their own patients and they have made their own recommendations. So what they decided was that for patients in whom SGLT2 inhibitors are given for cardiac or renal indication and they have no diabetes, if their fasting blood sugars are less than 126, they will proceed without stopping the SGLT2 inhibitor. However, if the patient is diabetic, then they will withhold for 3 to 4 days before elective procedure. Emergency, again, proceed with screening and treatment. Now, suppose by mistake one has forgotten to withhold, or you have asked the surgeon but they have not returned the order, then what they would do is ANAN gap less than 12 in a procedure which requires no GA and lasts less than 1 hour. and the total fasting duration is going to be less than 12 hours. Patient is well controlled clinically, is not received insulin, and has no other comorbidity, then they would proceed with such elective procedure. But even if one of these factors is negative, then they will reschedule the surgery. So again, the latest consensus recommendations, this has been recommended by the UK Association. What they have said that this is a shared decision-making approach. One needs to omit SGLT2 inhibitors on the day before and on the day of procedure, but one has to have avoiding of prolonged starvation time, and you restart this once the patient starts eating and drinking normally. You also monitor the capillary ketones and maintain them below 0.6 millimoles per liter. In bariatric surgery, they usually start the liver reduction diet 10 days prior to the surgery. So at that moment itself, you will have to omit the SGLT2 inhibitor and give a return sick day rule which states that if the patient is sick, they have to stop the SGLT2 inhibitor. However, the caveat is that this is a limited evidence. Evidence is still evolving, and again, they have also asked for large prospective studies to have a firm recommendation. So, intraoperatively, one needs to be careful about hypoglycemia as well as hyperglycemia. So, HGT monitoring 1 hourly or 2 hourly is recommended. Ketone monitoring. Now, we don't have this capillary or venous testing strip, so you can do a urine tip stick, and one needs to have an ABG. Intraoperatively, glucose and insulin should be given. Be careful of hypotension at induction and during positioning. And in view of increased risk of urinary tract infection, one needs to have a careful catheterization with full aseptic precautions if the patient needs a catheterization, and obviously antibiotic prophylaxis. So what is our summary? That be aware of non-diabetic use of SGLT2 inhibitor. I remember the first case where we came across this, the patient was receiving DAPA, and we thought that the cardiac surgeon meant, cardiologist meant dabigatran. And so we kept looking as to why dapagliflozin has been used in this case, which was a little long time back. And then we realized that it is being used for reduced ejection fraction. So be very careful when patients are non-diabetic but have heart failure, and therefore dapagliflozin may be presented. Also renal cases and obese patients. One needs to have localized protocols at one's institute because the clinical concerns are unique to your institutional protocol, and you have to weigh the risk versus the cancellation. Cessation time as per the drug for our usually our patients are on dapagliflozin, so 2 days, 2 to 3 days is recommended. That is 2 days prior and 1 day on the day of procedure. Ensure that the fasting periods are minimum and that they are not dehydrated. Give glucose and insulin, administer it intra-op and post-op as required. Keep assessing for euglycemic diabetic ketoacidosis with close monitoring of ANA and CAP, ketones with ABG when required. These are my references. Thank you for your patience.
Thank you, Aparna, for excellent presentation on SGLT2 inhibitors drugs. And I just want to do one comment on this topic. That I do only cardiac surgeries, and in cardiac surgery, if the patient is on this drug, and if the blood sugars are in acceptable limits, then I don't stop the drug on the day of the surgery, but continue the drugs, because what is happening if I'm stopping the drug, then sudden fluctuations in the blood sugars are really unpredictable. And sometimes, it is very difficult for me to manage the case. But if I continue the drug and I do the sugars monitoring and ketone bodies monitoring intraoperatively, when the surgeries are going for 6 hours or 8 hours, it is easy for me to manage it with, that whatever treatment is needed for during that time. So usually I don't stop if the blood sugars are in acceptable limits, but if they are giving the fluctuations, then I stop on the previous day. So this is what I do it for my cardiac surgery patients. Anyway, thank you very much. And question answer sessions will be in the last from the audience's side. So we will connect with you again. Now, I request Dr. Yogita to introduce the second speaker of this webinar. You can unshare your screen, Aparna.
So our today's second speaker is Dr. Shraddha Devrukar. She is additional professor at St. G.S. Medical College and KM Hospital, Mumbai. She has done a fellowship in cardiac anesthesia, and she has been really good with focus and 2D echo and all regional anesthesia. She has around 30 publications to her kitty, and she has been faculty to many conferences, and her special interest in fitness. She is a marathon runner as well. So welcome to Dr. Shraddha.
Yeah, thank you. Yeah. Hello, am I audible?
Yes, you are audible, visible.
Yeah. So thank you, ICA. Thank you, Pradeep Jain sir, Manjula Sarkar madam, and Yogita madam for giving me this opportunity to speak on this esteemed platform. So right from focused one single drug, let's enter into a big family of drugs, antipsychotic drugs and anesthesia concerns. So psychiatrists and anesthetists, though we work in the area, the organ of interest is the brain, we generally are facing each other's back. So we don't enter into their area and we prefer staying away from them. So how big is the problem? So is it really important to know that many details of antipsychotic drugs? Yes. As hypertensive, diabetic, even psychosis problems are increasing in India as well today. So 10 years back, when a survey was done, nearly 10.6% of the Indian population had some psychiatric disorder. Now in 2025, again, a survey started and probably a huge number is expected. So the psychotic problems are more in urban areas as compared to rural areas. And many initially there were only two phases, either depression or mania. But now many terms have been described in psychosis needing individualized treatments. So which drugs are commonly used? Antipsychotics, antidepressants, stimulants, and mood stabilizers. So it's a spectrum, mood is a spectrum. You have a psychotic depression at one end and the mania at the other. While we tend to walk on this spectrum or this given thread depending upon the amount of neurotransmitters varying in your brain at a time. So let's talk about antidepressant agents first, because that is a commonest problem in India today. Many people have depression and are dealing with it every day. So what is the primary pathology in depression? Generally is the monoamines which are required are reduced in brain. So we try to enhance it by giving these drugs. So tricyclic antidepressants, what does it do? It inhibits the reuptake of this amines which are secreted at the synaptic level. So there is another selective serotonin reuptake inhibitors. So at pre-synapse, it inhibits the norepinephrine uptake. So now combining serotonin and norepinephrine reuptake will inhibit both, again at a pre-synapse level. And there are MAO inhibitors which will prevent degradation of this monoamines which are formed. So all this thing in total will help in preserving your amines at the place. So many antidepressants, but the commonest or the first choice nowadays is SSRIs, which are commonly used. Fluoxetine, citalopram, escitalopram are commonest to have these patients. We do have patients coming up with these prescriptions. And the SNRIs, venlafaxine and duoxetine, especially in elderly patients, cardiac disease patients, they are preferred. While in terminal cases on requiring really having suicidal tendencies, then combination of SSRIs with tricyclic depressants are also seen. So generally what happens with antipsychotic drugs is when their mood or that symptom which they go for is treated, generally that dependence and tolerance happens with this drug and the side effects starts precipitating, which can affect our anesthesia management. So generally, all these drugs, when they act on amines, they are acting on your peripheral receptors as well, and they are causing anticholinergic activity by acting on the muscarinic receptors, which can cause your dry mouth, blurred vision, tachycardia, urinary retention, slowing gastric emptying, ileus, and delirium. So all these factors can get hyperprecipitated or synergistic effects get added to the anesthesia which we give. The cardiovascular effects are due to noradrenaline inhibition. Orthostatic hypotension is very common, especially in elderly patients. They get up from the bed and they fall. Is the commonest cause what you can have, which you can face similar thing happening in your postoperative areas also. Cardiac dysarrhythmias are very common, right from PR segment prolongation, QT prolongations, winning like effect on the myocardium itself can affect and have arrhythmias and sometimes heart failures. In CNS, sedation is going to occur, which can get exaggerated by all our anesthetic drugs. And some drugs also reduce the threshold, seizure threshold, especially this matters in kids. Yes, we are also getting kids with depression nowadays. So, what is the difference between tricyclic and antidepressant and SSRIs? SSRIs lack anticholinergic side effects, but it has an antiplatelet activity, which we will look further. SSRI also inhibit the CYP system in the liver. So what happens? The CYP system is involved in the metabolism of drugs. It inhibits or it can enhance. So sometimes the pro drug, commonly what we see with anesthesia practice is tramadol may not get converted to its active format and analgesic effect may be inhibited. While certain antiarrhythmics, they may have a sustained action and precipitate toxicity. And fluoxetine of this all is the maximum inducer, which is said to be 4 to 5 times. So let's see about SSRI and antiplatelets. So what has happened? It inhibits the serotonin reuptake. So the platelet aggregation becomes a problem. So there is a meta-analysis where they studied 42 observational studies were taken into this meta-analysis, and they found, yes, there is a positive correlation between patients who are on SSRI show a tendency of high bleeding as compared to those who are not taking SSRIs. So what do we do? So here, if the patient is undergoing some vascular surgery, some neurosurgery where bleeding is really a problem, consult with the psychiatrist, take a call to shift the patient to some other drugs, or if there are any concomitant anticoagulants which are used, stop them. Avoid using NSAIDs, antiplatelets, which can significantly amplify the bleeding risk. That has to be individualized as per the surgery and the patient status. So what are the anesthesia considerations? Continue the drug, it is safer. So they had done a study where they had studied the incidence of confusion and agitation, which was reported with antidepressants if they were discontinued for 72 hours was higher as in those which had taken those medications till the day. So what are the cardiac problems? I said orthostatic hypotension. So it can get potentiated if you're having long need for oral hours in subarachnoid block in elderly patients. So we have to be careful with this. You can expect some precipitous fall in blood pressure after giving a spinal anesthesia. Arrhythmias can be common. As I said, ECG is mandatory. So if there is an hypotension, a response to sympathomimetics is also very erratic. So it depends upon whether these patients are taking it for long term, when you say at least more than 6 weeks, and for short term, it is different. So what happens in long term is there is continuous exposure of these catecholamines at the receptor. So there is down regulation of this beta receptors and presynaptic alpha receptors. So what happens? You will need more drug than usual to treat them. And probably your indirectly acting drugs like ephedrine may not be effective, and you will need a directly acting vasopressors like noradrenaline, phenylephrine. They should be your drug of choice. While what happens in short term, since there is an excess of noradrenaline and catecholamines at the receptor levels, so both this direct and indirect acting vasopressors will have an exaggerated response. So what do you do is start with a small dose, say 1/3 dose and 1 pill, check for the response and accordingly go ahead. So hypertension, so avoid all those things which can stimulate sympathetic stimulation like ketamine, light plane of anesthesia. Overt sedation can be seen with anticholinergic if you're using them in preoperative rooms like glycopyrrolate and atropine. It can cause thickened secretions, and postoperative urinary retention can be a problem, especially in elderly patients having prostatic hypertrophy post-spinal anesthesia, opioid users. So you may need, so they can precipitate urinary retention and may need a catheter here. Serotonin syndrome can be precipitated, especially with phenylpyridine type of opioids. So here it is this phenylpyridine type of opioids, they are known to release uh, serotonin. So it can cause two reaction. One is type 1, which is an excitatory. So here the patient will have agitation, headache, hallucinations, and he will be agitated. While in inhibitory, it will be hypotension, comatose. So this excitatory type is due to facilitation of the serotonin, while inhibitory is due to the meperidine inhibits the hepatic enzyme and it stops its effect. So there is increased MAC requirement sometimes in patients. Opioid, if you're giving opioids, the respiratory depression effect will get enhanced. Use of multimodal anesthesia. Use of regional anesthesia of using local anesthetics. Use it without epinephrine whenever possible. So another commonly used drug in resistant depression and in phobias and in Parkinsonism nowadays has been the MAO inhibitors. So the enzyme which inhibits the metabolism of this drug so that persistent action is there. So there are two types of MAO inhibitors. A, which metabolizes serotonin, noradrenaline, and dopamine, while MAO B, which acts on tyramine and phenethylamine. So they are selective and non-selective. So selective will have lesser side effects, while as the non-selective are the irreversible ones. So that there is a permanent damage to that enzyme. So while in reversible, so here if you need to negate this effect, you will have to stop the non-selective beta inhibitors for pretty long time. For MAO inhibitors, moclobemide, which is available in India, since it is reversible, even if you stop for 24 hours prior surgery, it will give a positive effect. The MAO B selegiline, it is commonly used in resistance Parkinsonism and it is available as a skin patch. Again, MAO inhibitors are last of choice when it comes to prescription because you need to have control on food as well. So because tyramine excess like cheese, beans, avocados, all these things can precipitate a hypertensive crisis. It is more with non-selective and irreversible ones as compared to the newer reversible MAO inhibitors. Again, same serotonin syndrome can be seen even with MAO inhibitors. There even few cases with fentanyl are also noted, very few, but there are 2 or 3 in literature. Whereas food reaction, what happens in tyramine in food is not metabolized, so it enters into the circulation and cause hypertensive crisis. So such case can come to us in emergency or in ICU. So here the treatment of choice is to give injection nitroprusside. So stopping, if you need to stop the drug, you need to stop it 2 to 3 weeks prior. So what you can do is you can step to reversible or moclopomide, which can be stopped for 24 hours. But rather than having the newer anesthetic agents, which are pretty safe, modifying anesthesia management is advisable. So take care of your orthostatic hypotension, start patients on IV fluids when they are fasting. So orthostatic hypotension per se in MAO inhibitors is due to an octapane accumulation. It is a neurotransmitter with a lesser capacity of vasopressor effect. So again, take care of don't try anything which is going to cause sympathetic stimulation will have an bizarre effect of tachycardia, hypertension, arrhythmias. Use a multimodal analgesia. There is a drug called as phenelzine. So it is known to decrease plasma cholinesterase. So they can prolong neuromuscular blockade both with succinylcholine and mivacurium. So here, be careful with this while you are anesthetizing such patients. So let's see what is the serotonin syndrome. So anything excess, when any drugs or combination of drugs which will lead to excess of serotonin at the site will cause a serotonin syndrome. So all your MAO inhibitors, SRIs, and serotonin releasers. So our interest is, suppose a patient who is on antidepressants, maybe on some PCA and as well as an SRI inhibitor, but as a routine practice, we add our antiemetics to it. We give ondansetron, and here ICU MSET is going tedious. Plus, for long-acting surgery, we add some buprenorphine. So this combination of 2, 3 drugs can precipitate a serotonin syndrome. So what it is, there will be an agitation, confusion, anxiety, restlessness, autonomic dysfunction, your hypertension, tachycardia, hypothermia, diarrhea, neuromuscular abnormalities. Clonus is commonly found, hyperreflexia, which we sometimes think with this probably there is some infarct or some complication in the brain. In severe cases, you see rhabdomyolysis, myoglobinuria, renal failure, seizures, and even death is not uncommon. So what do you do is discontinue the serotonin exposure immediately. So many drugs have pretty long half, like fluoxetine and all will take some 4 to 5 days. Give a supportive treatment with fluids and oxygen. Sedation, it will calm down the patient. The metabolic requirement will come down. So benzodiazepines, midazolam is a good choice of drug there. And management of autonomic instability as per the needs. Like mostly these patients will be having hypertension, some arrhythmias, accordingly treat them. Hyperthermia is a big factor because of agitation and muscle rigidity also. There is rise in temperature. So antipyretics are mostly ineffective and external cooling, sedation, and relaxing helps. So the antidote to be used is cyproheptadine. It is basically a histamine 1 receptor antagonist with non-specific actions on serotonin receptors as well. It is available as 4 milligram tablet. So the dose is 12 milligrams should be given by an RT followed by 2 milligram every hour till the symptoms subside. So the another drug is lithium. So it is used in bipolar disorders. It is anti-maniac, antidepressant, anti-suicide. So when the patient is coming with a prescription of lithium, that means it's a terminal case. They have tried many things and now there is nothing else left. So lithium. So we cannot do much with this lithium, which is controlled his symptoms. So what it does, it reduces the neurotransmitters release both in central and peripheral nervous system. It takes but the advantage of lithium, it has a half-life of 24 hours. So it can be stopped 3 days prior to surgery and no withdrawal symptoms are seen. But it should be done with expert advice. So what are the problems with lithium is lithium mimics sodium in many places. So in kidney especially, it will compete with sodium in the proximal tubule, but not in the distal tubule. So anything when there is depletion of sodium will increase the lithium concentration and can precipitate its toxicity. So avoid dehydration, reduce sodium intake, especially in elderly patients where hyponatremia is very common. Use of thiazide and loop diuretics can again increase reabsorption of lithium and can precipitate toxicity. Lithium also inhibits intracellular AMP cycle, and you can see electrolyte imbalance. So look for your sodium potassium levels. And we need to know kidney function test every 6 months at least to know what is the kidney status and lithium concentration. So what does lithium also, as I said, it basically replaces sodium. So it that disturbs the conduction pathway of the heart also. So if there is some conduction disturbances and this patient is having some resistant psychosis and suicidal tendencies, and you need to put such patient on lithium along with a sick sinus syndrome, then a pacemaker is recommended. See, lithium also is known to cause hypothyroidism, especially in female patients. So every 6 monthly thyroid function test needs to be done. Lithium also interacts with neuromuscular blocking agents. So it prolongs both in depolarizing and in non-depolarizing. As I said, it mimics sodium and it interferes with the nerve impulse. And in scoline, it prolongs the onset, while in non-depolarizing, it will prolong the recovery. It potentiates the anesthetic drugs action because of central monoamine reductions. Lithium has a narrow therapeutic index drug, so you can have all these ECG changes and all sometimes in a very in a smaller dose as well. So in CNS, you can see tremors, hyperreflexia, nystagmus, ataxia, confusion, delirium, all are very common. Next group of drugs is for schizophrenia and antipsychotics. So the problem with psychosis is there is excess of dopamine, less glutamate, and increase of serotonin. So you need to block these drugs. So you have phenothiazines, thioxanthines, butyrophenones, and atypical antipsychotics. So this group of phenothiazines and thiazanthines, they will block the postsynaptic dopamine receptors in the brain, which control the positive symptoms such as hallucin. But the negative symptoms are not controlled with this. For them, you need atypical antipsychotics. And especially for mania patients, the commonest drugs are clozapine, quetiapine, which are weak dopamine agonists. So sometimes that same schizophrenia patients may be on this two drugs, two antipsychotics. And they also have so what happens with this? They also have this effects on Anti-dopamine effects because of extrapyramidal side effects will be there. Metabolic side effects, especially obesity, is commonly seen in them. Antihistaminic property, they may be sedatives, so it can precipitate, especially when you're using during TIVA cases, they can exacerbate this. Then antimuscarinic, anticholinergic effects are seen. Adrenergic receptor blocking, so hypotension is seen. So extramural, like I said, like tardive dyskinesia. So there is involuntary movements of the tongues, hand, limbs, acute dystonia reaction. So if the patient is on 1 year of antipsychotics, 20% of the patients will have this extrapyramidal side effects. And few 1% of the patients can also have dystonic reactions, aphylogasic crisis. And here the laryngeal dyskinesia presenting as laryngospasm, which can be an emergency where an anesthetist can be called to treat. So again, if this extrapyramidal side effects precipitate, these patients are very difficult to be placed for regional anesthesia, giving spinal or conducting a block. So in them, you need to sedate them first and then probably go ahead with your procedure. And the treatment for this extrapyramidal side, the diphenhydramine has to be given 25 to 50 milligrams. As I said, cardiovascular, it will have inhibitory effect on the vasomotor area, direct cardiac effect, and alpha blockades. It is maximum seen with thioridazine, chlorpromazine, and risperidone. So orthopedic hypotension, arrhythmias, prolonged QTC. So preoperative ECG has to be done. Other problems are impaired temperature regulation. The patient can behave like a poikilotherm because dopamine block in the hypothalamus. Anticholinergic side effects will be seen, and ventilatory depression effects of opioids are potentiated. So moreover, clozapine is known to cause granulocytosis. So take care while taking invasive lines, especially patients coming to intensive care. Type 2 diabetes can be precipitated with the same drug along with olanzapine as well. So these butyrophenones were age-old part of anesthesia where haloperidol still used in acute delirium and ICU psychosis, well as droperidol, neurolept analgesia as a combination with fentanyl is used as Inovar, an antiemetic. The caution with this particular drug is it can cause QTC prolongation. So drugs, so let's talk something about QTC prolongation. So anything more than 420, 450 is considered as abnormal. So any two drugs which can are concomitantly administered can prolong QTC and synergistic effect. So like suppose you are given some drug which inhibits the liver enzyme, that drug can enhance its effect and precipitate toxicity. So the commonest patient, so there are patient factors which are problematic are your congestive heart failure, bradycardia, hypokalemia, and elderly patients. And the drugs commonly causing or which we use familiarly are your antiarrhythmics, amiodarone, antifungals, and fluoroquinolones with macrolides in ICU setup. Antiemetic, commonest ondansetron and levofloxacin combination when you used in ICUs for long patients, elderly patients with an infarct. Not uncommon to have a prolonged QT. Rather, it's a black box advisory now. You should do an ECG before you start many drugs like this. Antipsychotic drugs, haloperidol or typical antipsychotics, and chloroquine. All these drugs can cause prolonged QTC syndrome. And this prolonged QTC syndrome, what happens? The heart becomes liable to go in torsades, which can be fatal. Let's talk about stimulants. Amphetamine, methylphenidate, cocaine, and MDMA. These are commonest uses are in for narcolepsy, ADHD, and depression, but they are more used for recreational use or off-label use. So what it does is it increases the dopamine, serotonin, and norepinephrine at the synaptic levels. So again, if they are chronic users or addicts, they will have depleted endogenous catecholamine stores, which would be resistant to sympathomimetic medications. While in acute cases, it's not uncommon to have acute, somebody has binged it, then they undergo some road traffic accident or to make some suicidal attempt and come for an emergency surgery. So you're calming them down, you're needing the requirement of volatile anesthetics increases since there can be dysarrhythmias and hemodynamic liability of this patient, invasive monitoring becomes mandatory. And with cocaine, as it's common to what I said before, the another problem is it can cause coronary vasospasms. So what are the anesthesia implications for this? Regional anesthesia is beneficial because we can monitor neurological status. Yes, but general anesthesia will control the CNS stimulation, reduce metabolic demand, manage cardiovascular issues, and facilitate cooling. Adrenergic blockade per se, beta blockers should be avoided because an unopposed alpha action will continue, which can precipitate hypertensive crisis. So labetalol can be used. For treatment of hypertension, directly acting vasopressors, inhalation requirement will be increased in acute state, and chronic state it goes down. Avoid scoline, which can precipitate hyperkalemia, and benzodiazepine, alpha-2 agonist, and propofol can be safely used. So, neuroleptic malignant syndrome, it is due to excess anti-dopaminergic effect. So, patient factors like recurrent dehydration and illnesses can precipitate it. Abrupt cessation of dopaminergic drugs can precipitate it. And it presents similarly something like serotonin syndrome and malignant hypothermia. There is hyperthermia, rigidity, muscle rigidity, tachycardia, cardiac dysarrhythmias, levels of consciousness will be seen. What do you do is discontinue the drug, give a symptomatic treatment, and the definitive management is with dantrolene and bromocriptine. Bromocriptine is 2.5 to 5 mg per orally, or through RT can be repeated 8 hourly. So this is neuroleptic. There are commonness. There is the symptoms are quite similar for all these syndromes. But in anticholinergic syndrome, the patient is generally the muscle tone is normal, while and dry. The skin and mucosa is dry, and the pupils will be dilated in anticholinergic syndrome and antisyndrome, which are normal here. But bowel serotonin will have parasympathetic hyperactivity, and there will be increase in bowel sounds, and the reflexes will be down in malignant hyperthermia. So this is the chart which will help us to probably reach a diagnosis when we get sudden emergency. And of course, the history will be very important in such patients. So take home messages, history may be sometimes very, so there should be a high degree of suspicion, especially in patients who are taking the stimulant drugs nowadays, which is very common, especially in the teenager group. Cognitive impairment is very common, so involve a family member to take adequate history. Most antipsychotics can be continued, but when you want to discontinue an antipsychotropic medication, weigh the risk of drug interaction with the anesthesia, risk of withdrawal symptoms, and risk of relapse or worsening healthcare. Most of this have QTC problems and PR interval. Do an ECG. Look for LFTs as it can enzyme inducers. Vasopressor use, opioids should be done with caution, taking care of precipitating serotonin or neuromalignant syndrome. So I hope at the end of the day we are incoherent, and thank you for this. I hope psychosis and anesthesia went together. Thank you.
Thanks, Dr. Shraddha, for excellent presentation. In the era of stress, I say that this is the era of stress, that everybody is in stress. You can unshare your screen. Everybody is in stress because of some other reason, and we are getting the patients, those are on antipsychotic drugs. If you see that, I think every third or fourth patient who is coming to you, that patient is on antipsychotic drug because of some other reason. So if you know the pharmacodynamic and pharmacokinetic of the drugs, and if you know what are the anticipated problems we are going to come across during intraoperative period, we can manage the patient well, and we can give the better outcome or better results from anesthesia part is concerned. So this is the common problem I think all anesthesiologists are facing in today's era. And this lecture is going to really help not only the students, but even the private practitioners. Those are coming across in such kind of the patients. So I request Rimpa to just see the audience questions if they have any for Shraddha and Aparna in the chat box.
Madam, I want to discuss one case. Shraddha is aware in our ICU only, in KM only.
Yeah, you can discuss.
Patient was admitted like a 73-year-old lady for fracture femur. And on table, she had sudden hypotension. Adrenaline infusion was started. Then she was shifted to ICU. Surgery need to be postponed. And then she was shifted to ICU. So ICU, once she was shifted, noradrenaline infusion, even though was continuing initially at cardiac dose, still her BP was not coming up. So we have to start adrenaline infusion along with noradrenaline. That time, 2D echo was done, ECG was done, even all the cardiac markers were done, and they all were normal, except that she had history of this antipsychotic drugs going on, that too in a therapeutic dose it was going on. But in spite of that, we have observed that resistant hypotension almost for 24 hours. And then after 24 hours, slowly, because her 2D echo was normal.
Antipsychotics.
Yeah.
Her
So Shraddha also has.
antipsychotics were, yeah, the antipsychotics were stopped probably, and then her receptors picked up. Yeah, even there was lot of hypotension, acidosis, which had come up.
So hypotension, which was not responding with the usual treatment of the
So probably
vasopressor.
we thought it is due to her long-term antipsychotics which were going on, and she was most of this psychiatric patient also have tendency to go to and take some herbal medicine, which also
Yeah.
has similar drugs.
Yes. So taking history and finding out what drugs patient is receiving, and you have to start the drugs, as soon as possible after your anesthesia. That might help in such kind of the situations if you come across. This is what you want to say,
And
correct?
generally, people don't want to share they are taking antipsychotics. That is a
Yeah,
bigger
correct,
problem.
correct. Yeah, they are very hesitant to
Yeah,
say that they are taking antipsychotic drugs because I don't know, still it is an that
stigma.
stigma that people don't want to share that I am on antipsychotic drug or I am facing the depression. Still, it is very difficult for common public to accept that this is like a disease, like a diabetes, hypertension, and you have to take the treatment. And there is no harm in saying that. And this, that.
Especially, yeah, especially these teenagers, they are taking a lot of
Yeah,
stimulants nowadays. And when they
correct,
come for the
correct,
shoulder surgery, we had unexplained tachycardia, hypertension. When we took
correct,
the
correct.
patient out, retrospectively, we came to know he was taking amphetamine, MDMA, which is commonly available, is very commonly taken nowadays.
Even our students are taking just, whenever they are just finding some problem, एक रेस्टी ले लेता हूँ मैडम एक रेस्टी ले लिया मैंने and you know that little bit of tachycardia because of whatever is reason they feel very happy, they feel अरे drug ले लिया तो then it is okay for me. So antipsychotic drugs and antidepressant drugs are very commonly used by the teenager group, even for the middle age, even for the geriatric patients. I found geriatric patients are also most of the time
They
they
are
are in.
commonly taking benzodiazepine, some form of
Ah,
still
correct,
very
correct,
common.
correct, correct, correct. So if you know that it is better for us also to give the better results and safe outcome from anesthesia, we can say that we have done the good job.
Yeah. Yes.
Yeah.
So, Dr. Shraddha, do you feel that there should be some protocol for patients on antipsychotics, ECG monitoring, and
Yeah,
postmortem
exactly.
also some monitoring
Especially
is required?
what happens as we are as an anesthesiologist, we are very familiar with antihypertensives, diabetic drugs. It's whenever something new comes into the market, we get into it, we try to know. The problem is we are somehow very reluctant to get into this antipsychotic drugs, and probably they're a little difficult as well. The mechanism of action goes. But we need to talk with our psychiatrist and try to get down it's which drug, because every day some new drug comes in, and they generally don't follow their principal group of drug, like though they are tricyclic inhibitors or SSRI. When I read all these drugs, every drug is in different pattern. So what I feel is if patient is on 2 3 antipsychotics at least, we should do an ECG, though he may not have problems with work efficiency or something, but PR segment prolongation, QT segment prolongation, some change in the progression of the RVO, and all such things need to be seen on.
I think
So,
ECG is a basic investigation
Yeah,
and we do for all the cases, so that should not be the very, as difficult task for us to do the ECG. But if you take the proper history and if you come to know the patients are on these drugs, that might help us in better ways, I feel.
probably you should have a high index of suspicion
Yeah,
Generally, the
correct, correct.
primary
Yeah.
surgeon can tell us better, when they are the people who see those
No,
patients
I
more
don't think
often.
so. Even primary surgeons are well aware regarding all these problems and all these concerns,
Yes.
because surgeons are only, most of the time, they are just concerned about
Aware
their
of the
surgery.
surgery.
Yeah. They don't, even they don't take proper history also. So that history taking and finding out is in the job of anesthesiologist only, I feel.
Yeah.
So we should be more particular regarding pre-anesthesia checkup time, and we should take all these factors into consideration and kept in our mind that these patients are highly suspicious patients and they might be on these drugs.
Yeah.
Second most common problem we face with this antipsychotic is managing delirium in the post-op period. So,
Correct.
age as such, we do give them regional anesthesia, and sometimes, handling them on table and a post-operative period
Yeah.
becomes so difficult. So, how do you manage, Dr. Shraddha, or what are your recommendations for such a delirium? How we can, curtail down on those delirium part for such patients?
Probably, initially, I think if the patient is on any psychotic drugs, we should generally consult the psychiatrist and counsel the patient well. Preoperative talking with the patient sometimes if they are non-cooperative for spinal anesthesia rather than forcing them कि एक छोटा सुई लगेगा prick है, might as well take that decision of doing it under regional and not doing under regional anesthesia, or regional anesthesia with a planned sedation is a better idea. Maybe
I
you
guess
have to
that
give,
really makes sense,
yeah,
using like dexmedetomidine for
yeah,
sedating and
some
all.
small
Because that
dexmedetomidine.
gives a lot of peace to everybody, to surgeon, to anesthetist, and maybe in the post-operative period also they are comfortable. Otherwise, sometimes
Even
it is
they're anticholinergic, they will have some involuntary movements as extrapyramidal side effects may be there, which may be very difficult for the patient to control as such.
plus hypothermia adds to all those involuntary
Yeah.
movements, especially under regional anesthesia. So it becomes very difficult. Sometimes, the surgery goes on more than 2-3 hours. Very difficult to really keep them peaceful and the environment peaceful. So hypothermia and all this delirium has to be really planned well, looking at the patient in the preoperative period only, I feel. So
Especially when you are doing the monitored anesthesia care and the patient will go into delirium and you have given a small dose of anesthetic agent as a sole anesthetic agent or whatever as a sedative. It is very difficult for us to find out whether it is because of the anesthesia problem or because of some other disease related problem or because the patient is on some drug, this problem is coming. So we have to really do the good pre-anesthesia checkup again and find out what are the suspicious means regarding the patient and regarding the drug is concerned.
now,
Also, the preoperative day, what I have found is sometimes the patient takes the drug sedative on the morning of the surgery, even though we have said no. We had one case of lap chole. She had taken all her drugs, means all her drugs were recommended, but a heavy dose of sedation she used to take in the morning, which we had said you withhold. But her mother was very particular that no drug can be missed. So she gave the drug. We didn't know. And the patient was sleeping afterwards because lab chole was over. But she was sleeping afterwards. And then the patient's relative told, no, no, no. The psychiatrist said, never you have to miss this drug. So that also we have to be
Correct,
careful.
correct. Yeah, we have to keep it in our mind. Yeah, that factor also.
so few
So,
questions to Dr. Aparna.
Yes.
Like you spoke about that euglycemic ketoacidosis in this SGLT2 inhibitor patients. So what are the intraoperative red flags supposed to be anesthetist picking up that we might expect the patient in the postoperative in a ketoacidosis? So are there any red flag signs on table we can pick up?
Actually, that is the problem with it. There are no red flag signs. In fact, patients in whom means now many patients are coming on dapagliflozin, and some have stopped, some have not stopped. But truly speaking, I have not found in my experience anything which suggests. And one thing is there, even though they were continuing, I have not found in the past, like so many years, the 2 years that I have seen patients on, I have not found so much euglycemic decay. And maybe that one study which was eye opening that we are not doing anion gap acidosis, we are not doing APGs for all patients. So if we do ABGs, then maybe we will pick up that anion gap acidosis. But clinically speaking, I have not had a problem actually. And
Ma'am, I in ICU for in 2 years we had two patients who had
okay,
developed post-dapagliflozin, but they were post-fracture patients. Both were fracture surgeries were quite prolonged, and did have this. So retrospectively, when we read the literature, then we could pint out probably. So we discussed it with our endocrinologist. Is what I feel is what they do is they just stop it for 48 hours,
hmm,
and then the patients is they don't add up anything to it.
exactly.
Yeah,
So
because
that
in
is the
their
problem.
advice, yeah, so in their advice, there is never they will say he's withheld it for 48 hours, but simultaneously in that same amount of food which he consumes, that sometimes I feel short, and then it becomes a complex, the surgical stress, sometimes adding, if you like all these spine surgeries, when you add dexamethasone to it post-operatively, and probably you get the
Yeah,
surge on the day 3, day 4.
yeah. Our surgeons,
Sometimes
they're doing
I feel
HGT monitoring. Sorry, yeah. They're doing
sometimes I feel that we always, stop the drug, but we always forget to restart the drug. So the restarting
That
the drug
doesn't happen.
is also equally important for prevention of any complication. This is what I feel. And
What I really feel is that gap has to be probably it's
With
taken care of.
insulin, probably,
Yeah,
for
because
better
hmm,
ketosis management, even better hyperglycemia also.
how about your opinion in your institute, ma'am? Because our institute endocrinologists do write it on paper nowadays to stop it for 48 hours, but that glycemic
no,
control, nothing has
no,
been added.
no, they have not asked. In fact, I am instructing the surgeon, and we do an HGT
Yeah.
monitoring.
Yeah,
But
because that we do pre-op and post-op, but
pre-op and
probably
post-op,
that 48 hours which happen, that baseline sugars, they really go high, because I don't know how much really in our setup, how much frequently the HGTs can be done, and all that becomes a real issue.
no,
Shraddha, I feel here that monitoring of SGT, in hourly
Mm,
basis, that hourly
mm,
or two, see, we do hourly monitoring in intraoperatively,
intraoperative.
and in ICU we do every 3 hours monitoring, and depending on that, we give whatever treatment is required. So, in the past, SGT monitoring was, as a day wise, that morning में हम करते थे या evening में हम करते थे. But nowadays we are doing on the hourly basis or 2 hourly basis or 3 hourly basis, depending on the need or depending on the patient's condition or whatever it is. So that really helps us. That really helps us. So hourly monitoring, what the way we do other monitoring, we should do SGT monitoring too for that 24 or 48 hours.
And for an ICU setup, generally when the patient goes in ICU, endocrinologists defer starting SGLT receptors till the patient comes out of ICU.
Yeah.
That is also what I've observed.
So when is the right time then to start in the
And
post-operative period, especially
because if the patient is sick, not well, they really,
not taking orally?
yeah,
Yeah, that is what is recommended also. Once they start
yeah.
drinking and taking meals orally, at that
Hmm.
time you have to restart the SGLT2 inhibitor.
Ma'am, what do you think? What I feel is like when you have this big extended surgeries where you plan your patient not going on per orals, maybe on day 3, day 4, we probably need to plan and change the drug only then, I feel sometimes.
Mm. Actually, yeah, maybe.
Hmm.
Because if you are
Hmm.
stopping na, for 40,
Yeah.
that this 48 and 72 hours actually rigorously has been started implementing quite recently. So
Yeah.
still
Because
maybe
in
we are
maybe
in
in
that,
this 6 months or
yeah,
so.
in 6 months it's become 3 days. With that
Yeah.
2 days and 24 hours, now I really didn't have that much of a problem. Now this 72 hours that they have said, that I think we will have to, maybe we will
Yeah.
start facing.
And what I felt of it is when they were stopping it for 24 hours, probably we generally keep a follow-up next day, or if the
Yes,
patient is in ICU,
yes.
and probably we have missed those.
Mhm. Maybe.
So same concern
Hmm.
happens in obese patient also, that they are on SGLT2 for weight management, and go for bariatric surgery. They are on liquids and they are not started on oral So is there any specific considerations in such class of patients and surgeries, those who come? They are basically to start on SGLT2 inhibitors for weight, but
No, they have
later on,
the the moment they have one thing that they have recommended is once they start on that diet for liver, they will stop the carbohydrate intake and all that. At that time only SGLT2 inhibitors have to be stopped. So for them, the recommendation is to stop quite early the
so
SGLT2
how many days
inhibitors.
early and post-op, how they start, or they change the
Usually 10
regime
days,
only?
usually 10 days before the bariatric surgery, this low carbohydrate diet and liquid diet is started. So 10
Mm.
days prior to surgery itself, SGLT2 inhibitors are omitted. And only restarted once the entire diet is done. Usually they are starting with 30 ml liquid diet and all that. So at that time, you are not starting the SGLT2 inhibitors. So bariatric, I think now in our setup, actually, they are delaying the meals and all later on. They are not starting everything very early. But I think in setups where it's more established, they may have another protocol. So
So it's
that
really
I'm not aware of.
means
Yeah.
there is not much of a literature, then very not very clear about how to go about it, and they are on SGLT2
Probably
inhibitors
more
before.
studies will answer the question.
Yeah, probably
Then now
because
they're going on the GLP ones, no?
Yeah.
Because SGLT2 with that, this now they're going on GLP ones because that's
Rather,
the
these two are in combination with
combination.
metformin
Yeah.
nowadays.
Now- So with all that, it becomes even more risky what to
Yeah,
start and when to start.
that is a
Okay.
commonest combination now. Thank you, madam.
Okay, then I think both the speakers has really done the very good job, excellent presentation, good clinical discussion, and most of the questions which were there in our mind has been really taken care by both of them very well. So I thank on behalf of ICA to Dr. Shraddha and Dr. Aparna for the excellent presentation. And now I request Dr. Pradeep Jain to conclude the meeting.
Pradeep just had to leave. He just called me
Okay.
10 minutes back
Okay,
that
so
I'm
should I
giving
conclude?
Yes, ma'am, please, ma'am.
Okay, fine. So I conclude the meeting and thank you very much for all of them, Dr. Yogita Patil, Dr. Aparna, Dr. Shraddha, and Dr. Vineet, and Dr. Rimpa to just conclude the meeting. And
thank you so much. Good night, all.
Thank you so much, everyone, for joining this session. Planet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone.
Thank
Have a
you.
good night.
thank you.
Good
Good
night.
night. Good night,
Good night.
everybody.
Happy
Yeah.
New Year, everyone.
Happy New
Yes,
Year,
Same.
everyone.
happy.
Yeah.
And I think this topic was related to Christmas only. Okay, good night, everyone.
Good night.
Good night,
Okay.
ma'am. Thank you, ma'am.
Thank you. Bye, madam.